am Professor Patrick.
Professor?
Dr. Professor Patrick.
So welcome back. We're going to be going through the GI section as well as endocrinology and hematology and nephrology. So the learning objectives for GI are to indicate causes of inherited abdominal wall defects, to interpret common causes of pediatric emesis, to differentiate pediatric causes of hematochezia, and to identify common pathologic causes of pediatric jaundice and their risks, and to contrast pediatric abdominal tumors. So starting out with pediatric abdominal wall defects, we've got a case of a G1 mother who presents with no prenatal history to the ED in labor, where she rapidly progresses to deliver. The newborn has exposed bowels laterally to the umbilicus, and immediate saline dressings and a plastic wrap is applied around the defect, and then an NG tube is placed. So this is gastroenterosis. It's not associated with any congenital abnormalities, but it's rather due to a vascular insult, and the treatment here is surgical repair with a staged closure. And there's there's an increased risk of neck, short gut syndrome, ileus, and reliance on TPN with this. So you want to look for lateral to the umbilicus and completely exposed GI. Next, we've got a G2P1 mom who presents to labor and delivery due to contractions. She's had sporadic prenatal care, and she was told there was an elevated screening level. After delivery, the newborn is found to have a herniated bowels contained within a membrane. So this is omphalocele. It's greater than 1/2 are going to be found concurrent with cardiac, neural tube defects, or trisomy syndromes. And the treatment here is going to be a staged surgical closure. Next case, we've got a newborn presenting to the pediatrician for a 1-month well child check. There's a persistent swelling at the umbilicus, and on exam there is a 1.5 centimeter defect in the midline that's covered by skin. And this is going to be an umbilical hernia. It's associated with African Americans, hypothyroidism, Ehlers-Danlos syndrome, and Beckwith-Wiedemann syndrome. And the treatment here is going to be surgery if it fails to close by 5 years, because that can cause complications and herniations. Last, we've got a newborn presenting to the ED on day of life 10. There's a lesion in the umbilical stump. On exam, there's a soft, moist, pink, pedunculated, friable lesion, and the parents are worried it's gotten infected and have applied antibiotic cream. And this is typical of an umbilical granuloma, and you can treat these in the office with silver nitrate. Moving into emesis, we've got a G1 mom who brings in her 5-week-old for persistent vomiting. She describes her boy's vomit as projectile, like an exorcism, but he wants to be fed after. On exam, there's increased skin turgor, sunken eyes and fontanelles, and an olive-sized mass in the left upper quadrant. And this is typical of hypertrophic pyloric stenosis, and this is common in firstborn males especially, and then it's pathognomonic with an olive-sized mass in the left upper quadrant. So the classic labs here are hypochloremic metabolic alkalosis, and the next best step is to do an ultrasound to confirm, and you can treat this first with fluid resuscitation and electrolyte normalization, and then they'll do a surgery to remove the obstruction. Next, we've got a 1-week-old newborn presenting to the ED with multiple episodes of bilious emesis. On exam, the child is inconsolable and draws up her legs and has abdominal distension. An NG tube is placed and fluids are initiated. X-rays are negative for any classic gas patterns or pneumoperitoneum, so this isn't neck or one of the obstructive causes. And we want to look for malrotation and volvulus. It's caused by failure to rotate 270 degrees around the SMA, and it causes a duodenal kinking on what's called Ladd's bands. The best step is an upper GI series, and then we want to treat these with a Ladd's procedure. Next, we've got a 2-year-old infant who presents with bilious emesis. The child was born via full term to a mother with limited prenatal care. On exam, the child has abdominal distension. An NG tube is placed and fluids are initiated. X-ray shows a double bubble appearance, which is classic for duodenal atresia. This is due to failure to recanalize in utero, and it's associated with trisomy 21. The next best step is a pre-surgical cardiac workup, because there's increased risk of cardiac abnormalities with trisomy 21. There's also jejunal or ileal atresia. This contains a triple bubble sign. It's due to a vascular accident, usually by cocaine or smoking. And then annular pancreas can commonly cause a double bubble as well. It's caused a clinical similar picture, and it's also increased in trisomy 21. Last, we've got a 1-month-old being seen at well child check. His mother describes him spitting up after feeds and naps every day, although he seems to be hungry and he's eating fine. On exam, his weight is progressing at the 50th percentile. And this can be due to GERD, or gastroesophageal reflux. This is due to short esophagus length and incomplete closure of the lower esophageal sphincter, and you can treat this with repositioning. If there's concern for failure to thrive and irritability, you can move on to thickened foods. You can add rice cereal, or frequent feeds, antacids, and pH monitoring. So for the patient with a delayed meconium, we've got two options here. We've got a case with a 3-year-old newborn who presents for failure to pass stool. She was born at full term without complication to a Caucasian family at home with routine prenatal care. On exam, the abdomen is distended and the anus is patent with normal tone. X-ray shows dilated loops of bowel. The next best step here would be a contrast enema, and you want to show a microcolon and obstruction in the ileum, and this would confirm the diagnosis of Meconium ileus. You can do a sweat chloride test because Meconium ileus is strongly associated with cystic fibrosis. Next, we've got a 2-day-old newborn awaiting release from the hospital due to failure to pass Meconium. He was born full term without complication, and on exam, the abdomen is distended and the anus is patent with increased tone. Upon rectal exam, there is a release of a large amount of stool, or a squirt sign. The next best step would be a contrast enema showing narrowed sigmoid and dilated descending colon, and the confirmatory test for Hirschsprung's disease is a vacuum-assisted rectal biopsy. You want to show the lack of a myenteric plexus. Next up, with baby bloody stools, we've got a case of a 4-day-old in the NICU who develops bloody diarrhea and hypotension. He was born at 34 weeks and required to stay in the NICU for respiratory distress. He's currently formula fed, which is a risk factor. And on exam, there's abdominal distension and tenderness. X-ray shows pneumatosis intestinalis, or air within the wall, and portal venous gas. So this is necrotizing enterocolitis, or NEC, and it's treated with parenteral nutrition, broad-spectrum antibiotics, and it may require surgery if there's any necrotic portions. Complications include sepsis, strictures, and short gut syndrome. Next, we've got a 6-week-old Caucasian girl who presents for bloody stools. She was born full term. She's been seen multiple times for difficulty gaining weight and reflux. On exam, there's abdominal tenderness without distension and an erythematous rash in the flexor surface. And this is diagnostic for milk protein allergy. It's due to a non-IgE mediated immune reaction, and it cross-reacts to milk and soy protein. The treatment is going to be elimination of milk and soy from breastfeeding mother's diet, or hydrolyzed formula, and almost all infants can tolerate dairy and soy products by 1 year old. Next, we've got a 2-year-old boy who presents to the ED with bright red blood in his stool. He is not in any pain, and he has not had any change in bowel habits. X-ray shows no pathologic pattern, and this can be a Meckel's diverticulum. You can diagnose this with technetium M99 scan, or you can treat it with surgical removal to prevent any recurrent hematochezia volvulus or intussusception. It can be a point for volvulus and intussusception. So the rules of 2 here, it's a 2% prevalence worldwide, 2-to-1 male to female ratio. It often presents at age 2, and there are 2 different types of ectopic tissue. There can be pancreatic or stomach tissue, which causes a lot of the hematochezia. And it's usually 2 feet from the ileocecal valve and about 2 centimeters in length. So last, we've got a 1-year-old who presents with bloody stools and colicky abdominal pain. 2 days ago, she began to have diarrhea, and this changed to current jelly stool this morning. On exam, there's a sausage-shaped mass in the abdomen, and this is intussusception. Abdominal ultrasounds may show a target sign, and you can diagnose it and treat this with an air contrast enema. Sometimes the lead points can be Meckel's and HSP, tumors, polyps, or lymphadenopathy. Going into celiac disease, we've got a 13-year-old girl who presents with years of abdominal pain, bloating, fatigue, and short stature. She was recently started her menstrual periods, and she's seeing a specialist due to heavy flow and anemia. On exam, there's a papulovesicular rash seen on the extensor surfaces of her arm. And the next best step here, if you're considering celiac disease, would be an anti-tissue glutaminase, IgA, and confirm this with a flattened villi on small bowel biopsy with EGD. And you can treat this with a strict gluten-free diet. It's associated with IgA deficiency and HLA-DQ8. So the child with jaundice. So we've got a newborn presenting with a yellow color of its chest and eyes. The next best step is to do a bilirubin check to know exactly what the levels are. Say this was a 3-year-old born full term without complications, has normal activity, feeding, and elimination. Bilirubin is 9 with an elevated unconjugated bilirubin. The diagnosis would be physiologic jaundice. This is due to liver conjunction immaturity, and it usually resolves by 1 week. Next, we've got a 1-week-old boy born full term without complications, has normal activity. He's breastfed 15 minutes per side every 3 hours. On exam, the fontanella is depressed minimally with dry mucous membranes, and bilirubin is 12 with an elevated unconjugated portion. The diagnosis here would be breastfeeding jaundice. This is due to a slight dehydration and increased absorption of conjugated bilirubin. So breast milk actually inhibits conjugation of bilirubin, and this is thought to be sort of a inflammatory benefit because bilirubin can catch free radicals. Next, we've got a 1-week-old boy born full term. They're found to have pale colored stools. Labs show a bilirubin of 9 with an elevated direct bilirubin and elevated LFTs. So this can be biliary atresia. It can cause liver failure and it needs surgical correction. Last, we've got a 2-week-old born via full term without complications, and he's regained his birth weight. She's breastfed for 20 minutes each side for every 2 hours. And on exam, there's scleral icterus. Bilirubin is 9, and it's mostly unconjugated. And this is breast milk jaundice, not breastfeeding. So at this point, he's getting adequate amount of breast milk, so he's no longer dehydrated. But the breast milk itself has a inhibiting enzyme in it. So now pathologic jaundice. If there was a 2-day-old born at 39 weeks by C-section to a G6 mom, and it's found to have scleral icterus and fluorescent yellow skin, bilirubin is 15 with mostly unconjugated and a high slope. So you'll notice all the pediatrics attendings and residents will wear cards that have a bilirubin graph on it. So the next best step would be COMLEX to check for an ABO or RH incompatibility. And you have to rule out sepsis, galactosemia, hypothyroidism, or colodocal cysts. Some causes of direct bilirubin elevation would be Dubin-Johnson syndrome or Rotor syndrome, and causes of an elevated indirect bilirubin is G6PD deficiency, Gilbert's, or Crigler-Najjar's. And the risk of kernicterus, or deposition within the basal ganglia, increases when bilirubin gets above 20 to 25. And you want to treat this with phototherapy or exchange transfusion, depending on where they fall on the graph based on their birth week and slope. Some older jaundice questions. We've got a 5-year-old who presents with a change in mental status 1 week ago. She had a viral illness with fevers, chills, rhinorrhea, and nausea, and she was tested for influenza and treated for her symptoms. Increasingly, she's become more lethargic, and on exam, there's scleral icterus and considerable hepatomegaly. So this is Ray's syndrome. You want to look for increasing LFTs, PT, INR, and ammonia, and liver biopsy will show microvesicular fat infiltrations, and you can only treat this with supportive care. So this is why there are warning signs on all your aspirin products, recommending not to give it to children less than 6 years old. Now we've got an 8-year-old who presents with yellowing of his skin and abdominal pain. Abdominal pain radiates to his back and causes considerable nausea. On exam, there's a palpable mass in the right upper quadrant and generalized jaundice skin. This is a biliary cyst. The most common is type 1. And the next best step is right upper quadrant ultrasound, or ERCP. And you want to treat this with surgical resection because there's an increased risk of malignant transformation. So with the patient with colic, we've got a case of a 2-month-old who presents for well child check. Her mother is visibly distressed, and she says that every day for the last month, her infant has cried nonstop. And it's like clockwork, starting at 6 p.m. until nighttime, and she's unable to console the child. On exam, there's no abnormalities, so the diagnosis would be colic here, and you have to rule out any corneal abrasions, hair tourniquets, or milk protein allergies, any organic causes of a child discomfort, and you want to screen for non-accidental trauma and postpartum depression. This increases in newborns with colic. You want to reassure the parents and review the feeding and calming techniques, but this usually self-resolves over time. Some GI parasites to know. A case of a 5-year-old presenting with intense perianal itching, especially in the early morning hours. His mom notes that nothing has changed with his diet or elimination habits, and he's complained of abdominal pain and nausea. The diagnosis would be Entamoeba vermicularis. The next best test is the Scotch tape, and you want to sterilize the entire room and treat the whole family with albendazole or parental pamoate. Next, we've got a 12-year-old Chinese immigrant who presents with shoulder and arm muscle pains. For the last week, he's felt febrile and nauseous, and on exam, there's significant periorbital edema and conjunctivitis. CBC shows marked eosinophilia, and the eosinophilia, periorbital edema, and muscle aches is classic for trichonellosis, and you can treat with mebendazole or albendazole and steroids. So going into some GI tumors, commonly is a Wilm's tumor versus a neuroblastoma. So you've got a 15-month-old male who's brought into the physician due to a flank mass found while his mother was bathing him. So these are the most common question scenarios for both of these. The next best step is abdominal ultrasound, and the most accurate test is a CT chest, abdomen, pelvis. So if this is a Wilm's tumor, the mass is commonly not crossing the midline, and this is due to a Wnt gene, and there's associations with Wagger, which is a Wilm's tumor, aniridia, GU abnormalities like a horseshoe kidney, and retardation, or Beckwith-Wiedemann syndrome, where you get hemihypertrophy, organomegaly, macroglossia, and wall defects. Versus a neuroblastoma, which this mass commonly crosses the midline. It's due to an N-MYC gene, and it's a tumor of the adrenal medulla. It's associated with opsoclonomyoclonus syndrome, or dancing eyes, dancing feet. Going into some pediatric x-rays, we've got malrotation and volvulus here, where you can see the dilated loops of bowel, and then the progression of the contrast stops. Next, we've got a double bubble sign, so you can see the bubble in the stomach as well as duodenum. Next is Hirschsprung's disease, so you can see there's a dilated colon, which is the normal portion, and then at the sigmoid there becomes a bird's beak abnormality, and that's where the myenteric plexus stops. Next is Meconium ileus, so you can see the blockage is in the ileocecal area. Next is necrotizing enterocolitis, so you can see air within the wall of the abdomen. And then an intussusception, this is a target sign on ultrasound. So moving on into nephrology, the learning objectives here are to identify common congenital genitourinary abnormalities and their associations, to interpret common causes of UTIs in the Peds patients, to classify and manage causes of enuresis, and to differentiate nephrotic syndromes and devise their causes, and then to contrast differing pediatric testicular pathologies. So some GU congenital abnormalities. Say we've got a G2P2 mom who gives birth to a boy at full term. On initial newborn screening, it was noticed that the opening of the urethra was abnormal. So if it's either epistates or the urethral opening on the ventral surface of the penis, which is highly associated with bladder extravasity and needs surgical correction, or hypospates, the urethral opening is on the dorsal surface of the penis and it's highly associated with cryptorchidism and inguinal hernias, the patient should remain uncircumcised to allow surgical repair. Next, we're going to have UTI. So we have a case of a 1-year-old girl who presents due to increased fussiness and fevers over the following days. Her mother did not notice ear pulling, coughing, rhinorrhea, rashes, or changes in stool. Vital signs show a temperature of 39.1, and on exam, lungs are clear to auscultation. The epigastrium is tender, and tympanic membranes are normal. So the next best step would be a straight catheterization with urinalysis and culture if they're unable to provide a clean catch urine for you. So serum BUN creatinine is used to estimate renal function, and then a renal ultrasound is usually offered if the first UTI is less than 24 months old, if there are recurrent UTIs, or if there's a family history of renal anomalies, or if they're not responding to normal treatment. So there's a possible history of a renal abscess. So a common disorder here is vesicouretal reflux. It can be diagnosed following an abnormal renal ultrasound by avoiding cystourethrogram. So renal scarring can be monitored by renal scintigraphy or dimercaptosuccinate acid. And then lastly, we've got posterior urethral valves. It's more common urinary obstruction in newborn males. You can cause bladder dystrophy, oligohydramnios, or Potter sequence, and you can treat this with a PUV ablation. And then the treatment for any UTI is going to be 1 to 2 weeks of antibiotics. So for enuresis, we've got a case of a 5-year-old girl presenting for enuresis at least 3 days a week. She is dry during the day, and she's never had dry events overnight. Exam is unremarkable, and urinalysis is negative for glucose or ketones. So this would be primary enuresis, never having dry events before. The next best step is environmental and lifestyle factors. So avoiding caffeine, voiding during the day regularly and before bed, drinking ample fluids in the morning but restricting it at night, and then reward systems for dry nights. And then second line treatments you can try as an enuresis alarm. And then drugs like desmopressin and TCA are usually limited for second line therapies. Next case, we have a 6-year-old boy who presents for increasing bedwetting. He has previously been continent for 2 years, and his mom has noticed no increased thirst or hunger, so not a DKA or diabetes type picture. And he recently became an older brother. Exam shows no suprapubic tenderness, so there's no UTI-like symptoms. So the diagnosis here would be secondary enuresis. And the next step is to identify and correct any underlying condition. So some of the causes are stress and UTIs, diabetes or diabetes insipidus, and obstructive sleep apnea. Next is proteinuria in pediatrics, so nephrotic syndromes. We've got a 4-year-old boy who's found to have 2+ protein without hematuria on a screening dipstick at a well-child event. He does not have anasarca or foamy urine. His mom denies any prior throat or skin infections, so it's not likely any of the classic nephritics or nephrotics. The next best step is to repeat the urine dipstick on 2 occasions and try to include a first void, because this can be transient just due to stress, fever, exercise, or orthostatic, which is common in adolescent boys. It resolves when they're recumbent. Next, we've got a case of a healthy 6-year-old child who presents with foamy urine and edema. His mom noticed his eyes appeared puffy and his urine was very frothy. Dipstick shows 4+ protein, so within the nephrotic range at this point. There's no hemoglobin, nitrates, or WBCs. The next best step is a 24-hour protein in creatinine or protein creatinine spot. And then a renal biopsy can be the definitive diagnosis, and you're looking for effacement of podocytes on scanning electron microscopy. And the diagnosis is minimal change disease. It's common in kids. It's due to T-cell dysfunction. And there's an increased risk in elderly individuals who have this with lymphoma. And it can cause a nephrotic syndrome. You can treat with steroids for 4 to 6 weeks, and it commonly resolves. Moving into hematuria or nephritic syndromes, there's an 8-year-old who presents with red urine 3 days following a URI. He's had 2 episodes of this happening before, following a diarrheal illness and a URI. So this is IgA nephropathy. It's the most common nephritis worldwide, and it has mesangial deposits of IgA and C3, and it usually follows 1 to 7 days following a mucosal infection. So any infection that's going to release IgA subtypes. And then the timing is key. It's 1 to 7 days. We can compare that with the next vignette. So we've got a 12-year-old who had a sore throat 2 weeks ago, who was treated at an urgent care and now presents with dark-colored urine. His mother noticed increased swelling and thirst the last 3 days. On exam, his BP is 132/89, which is elevated for a 12-year-old. And there's pitting edema of the hands and feet. So this would be post-streptococcal glomerulonephritis. It occurs 2 to 3 weeks following a group A beta-hemolytic streptococci infection. So this would be both a skin infection or a throat infection. To confirm, you would want to do ASO titers and complement levels. And then this usually self-resolves after about a week to 2 weeks. Next, we've got a 16-year-old with a history of progressive deafness and increased oliguria. He has no history of AOMs or meningitis, and there's no family history of hearing concerns. A urine dipstick shows 2+ hematuria and 1+ proteinuria, no nitrates or WBCs. So this is Alport syndrome. It's an X-linked defect in type 4 collagen. It leads to sensory neural hearing loss and hematuria and proteinuria. So the classic sign here is can't pee, can't hear a bee. And you can treat this with kidney transplantation. Going into testicular pathology, there's a healthy 1-year-old boy who presents for well child check. On exam, there's an empty, hypoplastic, poorly rugated scrotum with inguinal mass. So this is cryptorchidism. It's associated with prematurity, neural tube defects, and genetic disorders. You want to treat this with orchiplexy. There's an increased risk of infertility and testicular cancer, and this does not remove the risk, but it allows for easier surveillance. Next, there's a 16-month-old with a scrotal swelling. On exam, the mass transilluminates with a pen light. So this is a hydrocele. It's a communication with the processus vaginalis, and most will resolve spontaneously by 12 months. You can need to treat with surgical intervention if they're not resolved by 1 year because there's a risk of inguinal hernias. Now we're on to the endocrinology section. The learning objectives here are to identify and prevent the complications of congenital hypothyroidism, to determine primary pediatric pathologies of infants of diabetic mothers, to evaluate and interpret the management of DKA, and to differentiate causes of precocious puberty. So for congenital hypothyroidism, we've got a case of a 6-week-old infant who presents for lethargy and poor feeding. He did not pass meconium until 48 hours and has had 1 to 2 stools per day that appear pellet-like. He was born at home to a G1 mom and did not receive prenatal care or after-birth care. And on exam, there is jaundice, large fontanelles, a large tongue, and umbilical hernia. The next step here to confirm would be TSH and free T4. This is done on newborn screening most of the time because without treatment, this can lead to intellectual disabilities and what's called cretinism. So some of the causes are thyroid aplasia, so they're born without thyroid tissue, hypoplasia, or ectopic glands, and there can be transplacental maternal TR receptor blockers, and you want to treat this with levothyroxine. So for infants of diabetic mothers, we've got a case of a 6-hour-old newborn being examined by the pediatrician. She was born to a G1 mom with gestational diabetes at 41 weeks by forceps-assisted delivery. On exam, there's crepitus over the shoulder. So large for gestational age confers the risk of delivery trauma like shoulder dystocia or clavicle fractures, and C-section and TTN. There could be rapid tonic-clonic movements. So blood glucose is low due to maternal hyperinsulinemia or hypocalcemia. So you have to check with AccuChecks on an infant of diabetic mothers. And then lastly, there's increased yellowing of the skin. And this jaundice can be due to relative polycythemia and breakdown of RBCs, and there's an increased risk of kernicterus in infants of diabetic mothers. Moving on to DKA, we've got a 12-year-old with a history of allergies who presents to the ED obtunded. His family's noticed him drinking and peeing a lot in the past few days. On exam, he's hypotensive with rapid, deep breaths and has a fruity odor. Labs show glucose of 671, sodium of 153, which is a pseudo-hypernatremia, and potassium of 3.1, chloride of 108, and a bicarb of 12. So there's a high gap here. Your diagnosis is DKA. It requires ketonemia and acidemia in the diagnosis. Your next best steps are to start 2 large bore IVs, and you initiate rapid saline infusion, and you start an insulin drip. Eventually, you're going to need to monitor potassium and supplement extra potassium in one of these bags as well. And you're going to monitor glucose and anion gap. So you can transition once the gap closes and the glucose is lowered to subcutaneous insulin. And then you need to monitor for cerebral edema and respiratory depression with neurochecks every 2 to 4 hours. So type 1 diabetes is caused by autoimmune destruction of beta cells within the pancreas. Some puberty pathology here. We've got a case of a newborn girl presenting with emesis and ambiguous dentachalia. She was born to a G2, P2 mom with normal prenatal history and delivery, and vital signs show hypotension and tachycardia. Exam shows clitoromegaly and a normally palpated ovaries. Laboratory studies show hyponatremia and hyperkalemia. So the diagnosis would be congenital adrenal hyperplasia. The next best step is a 17-hydroxyprogesterone level, and you can treat this with cortisone and mineralocorticoids. Next, we've got a 13-year-old girl who presents with hirsutism. On exam, she's Tanner stage 4, and her gonads are palpated in the labia. Karyotype analysis shows 46XY, so this is 5-alpha reductase deficiency. And then last, we've got a case of a 16-year-old girl who presents with amenorrhea. On exam, she has stage 4 breasts and pubic hair without axillary hair. Vaginal exam reveals a shortened canal without a cervix, and ultrasound confirms the absence of a uterus and a small internal gonads. The diagnosis is androgen insensitivity syndrome here. Some more pathology. We've got a case of a 12-year-old boy brought to the pediatrician because he's the shortest in his class. He has no past medical history, and he was born at normal weight and development. His parents are 6 foot and 5'9", but he's tracking along the 7th percentile for height and 12th for weight. So this would be constitutional growth delay. The next best step is a bone age. It's usually less than the chronological age, and you can treat this with reassurance and the fact that a growth spurt will come soon. Next, there's a 6-year-old girl presenting with increased hair and breast bud development. On exam, she's the 78th percentile for height and 98th percentile for weight. X-rays show bone age is 2 years older than chronological age, and GRNRH stimulation test is performed, and MRI, brain, and CT were all without tumors or cysts. So this is precocious puberty. It can be due to brain tumors, abdominal dysplasias, and obesity, as this case is. And you can divide into central versus peripheral. You need to rule out any tumors or atypical CAH or cysts. Last, we've got a 4-year-old boy presenting for abnormal growth and leg pain. He's had a normal birth history, and he follows the normal growth curves until age 3. He's at the 97th percentile for height and weight, and on exam he walks with a noticeable limp and uneven leg lengths. He has jagged teeth, a pigmented macule on the back of his neck and buttocks, and affected one side, so that would be a cafe au lait spot. MRI of the brain shows no pituitary lesions again, and this is McCune-Albright syndrome. It's caused by activation of GNAS, and the treatment for the fibrous dysplasia with bisphosphonates, and you need to monitor for endocrinological abnormalities. Going into hematology and oncology, the learning objectives are to discriminate the cause and management of pediatric anemias, identify common complications of sickle cell anemia, interpret the cause of common microangiopathic disorders and management, and then differentiate the subtypes of leukemia and lymphomas and identify pathologies from blood smears. For iron-deficient anemias and thalassemias, we've got a case of a 2-year-old brought to the physician for a well-child check. He will refuse to eat anything but a glass of milk. On exam, there's pale conjunctiva, and a smear shows hypochromic microcytic anemia, and this is iron-deficient anemia. It's common in picky eaters, especially after 18 months, and you need to treat this with iron supplementation and varied diet. Next, there's a 3-year-old African-American boy presenting to his pediatrician for routine screening. He has a family history of anemia. Hemoglobin is 12.8, MCV is 67, and RDW is 13. The smear shows a hypochromic microcytic anemia and target cells. This is diagnostic for alpha thalassemia minor. It's usually asymptomatic and it doesn't require treatment unless there's symptoms. So you can see the RDW is small despite the MCV being extremely small, and this is because all of the RBCs are made similarly with very small MCV because they're not being filled with enough hemoglobin. Next, we've got a 6-month-old Italian boy who presents to the pediatrician for failure to thrive. On exam, there's scleral icterus, an enlarged spleen, and characteristic chipmunk face. Hemoglobin is 6.2 with hypochromic microcytic anemia and target cells. So this is beta thalassemia major or Cooley's anemia. On X-ray, you can see crew cutting or vertical shifts because of the iron deposits in bones. Treatment requires frequent transfusions, and there's a risk of iron toxicity and secondary hemochromatosis. So lead exposure. We've got a case of a 3-year-old brought into the physician's office for a well-child check. His grandparents raised him on the farm that was built by his father and father's father. And since moving to the farm, he learned the word no and refused to eat anything but milk. He has had behavioral problems, and his speech has not progressed beyond 1 to 2 sentences. On exam, there's mild tenderness in the abdomen and pale conjunctiva. The next best step is a hemoglobin hematocrit to confirm anemia, and you can do a blood lead level. Levels should be less than 5 decigrams per deciliter. X-ray shows dense metaphyseal lines or lead lines, and screening is usually done by a questionnaire and blood lead level at 1 to 2 years of age. Houses built before 1978 constitute a risk of having lead paints, and then communities near lead mines or with old plumbing are also increased risk. You can treat with lead chelation therapy when the blood level is greater than 45 micrograms. So EDTA, dimercaprol, or succinimir are all options here. For sickle cell disease, we've got a case of a 4-year-old African-American girl with painful hands and legs. So dactylitis is the most common presenting symptom. On exam, there's scleral icterus, a palpable spleen, and painful swollen dorsum hands. Hemoglobin is 8.2, MCV is 87, and RDW is 24, and peripheral smear shows sickling of the cell. So confirmation can be done with hemoglobin electrophoresis. And the common cause is an autosomal recessive condition common in African and Middle Eastern descent. There is a heterozygote advantage where carriers were less susceptible to malarial infections. And then complications, which we'll go over next, include acute chest syndrome, splenic infarcts, avascular necrosis, priapism, strokes, blindness, abdominal crises, renal papillary necrosis, aplastic anemia, ulcers, and salmonella osteoarthritis. And you want to treat any crisis with IV fluids, morphine, warming, and oxygen. Long term, you can prevent crises with hydroxyurea by increasing fetal hemoglobin. And then secondary prevention of morbidity with penicillin prophylaxis for any diagnosed under 6. Decreases the risk of strep pneumo sepsis. And then vaccines against encapsulated organs because this splenic autoinfarcts. Folate administration, hydration, temperature control, and altitude control are all helpful. So some of these complications. So say after soccer practice on a hot day, she has chest pain, fever, coughing, shortness of breath. This could be acute chest syndrome. You need to treat with exchange transfusion, antibiotics, and oxygen immediately. Next, if she presented with acute confusion and focal neurologic deficits, this could be a stroke, and you would need a transcranial Doppler, and you would treat with exchange transfusion. Next, if they presented with fever, tachycardia, warm extremities, and lethargy, this would be worrisome for sepsis due to strep pneumo. So the encapsulated organs have an increased risk of infection. So treatment would be appropriate. Next, if there was acute respiratory distress, drooling, and tripoding, this could be Wilderner's ring hyperplasia, and you can treat this with emergent tonsillectomy. Next, if there were point tenderness on the tibia, fever, malaise, and leukocytosis, this could be osteomyelitis. It's most commonly due to Staph aureus, but those with sickle cell disease have a much higher rate of salmonella infection. And then lastly, if there was an acute drop in reticulocytes with a febrile URI and a rash, say a rash on the cheek and upper extremities, this could be aplastic crisis due to parvovirus B19. So some rarer types of anemia that tend to show up on pediatric exams. If there was a 4-year-old girl presenting with fatigue and bruising after a viral illness, on exam there's considerable pallor. Hemoglobin is 7.3, WBCs of 5.9, and platelets are 172. This could be a transient erythroblastosis. The next best step would be bone marrow biopsy, and you can treat with bone marrow transplant and judicious transfusions. Next up, a 4-month-old is seen for failure to thrive. The baby has pallor and long finger-like thumbs, or triphalangeal thumbs. Laboratory studies show hemoglobin of 6.3 with low reticulocytes. White blood cells are 6.7 and platelets are 212,000. So this is diamond blackfen anemia. You can treat with steroids and transfusions, and the cure is a bone marrow transplant. And then the last one is a 6-month-old being examined for failure to thrive. He has a history of congenital heart lesion, scoliosis, and abnormal hearing tests. On exam, there's a darkened patch of skin resembling a coffee stain or a cafe au lait, and odd-shaped thumbs. Laboratory studies show hemoglobin of 6.5 and low reticulocytes, and WBCs of 1.7 and platelets are 52. So this is Fanconi's anemia. You can diagnose with cytogenic studies. And then there's an increased risk of malignancy during life. You want to treat with steroids and transfusions, and you can cure this with a bone marrow transplant. For ITP and HUS, we've got a case of a 7-year-old girl 2 days after epistaxis. On exam, there's Petechiae purpura and ecchymoses, and there's no splenomegaly. Platelet count is 12,000. So this is immune or idiopathic thrombocytopenic purpura. You can treat this with steroids or IVIG. It often resolves in pediatric patients. Rarely you can do a splenectomy. Next, there's a 3-year-old with petechiae, abdominal pain, vomiting, and lethargy. He last urinated 12 hours ago, so oliguria, and he's had bloody diarrhea for 5 days after eating a hamburger at a state fair. Labs show thrombocytopenia and increased creatinine, and a blood smear shows schistocytes, so those are diagnostic of hemolytic uremic syndrome. The most common bug is E. coli 0157H7. It's also Shigella, Salmonella, or Campylobacter, and you can treat this with supportive care, fluids, and dialysis. You do not want to give platelets or antibiotics to these patients. For HSP, Henoch-Schonlein Purpura, we've got a case of a 3-year-old girl who presents with rash and abdominal pain. Her father notes that she will all of a sudden bend over in excruciating pain and cry, and then return to her baseline and play. On exam, there's symmetric palpable purpura over the buttocks and lower legs. The next best step here is an air contrast enema for the likely intussusception, and you want to look for a target sign. Urinalysis might show hematuria. Up to 20% of patients can have renal disease after the initial illness. And the treatment is hydration and NSAIDs. Steroids is the preferred treatment for severe disease or if they have intussusception. So hemophilia and von Willebrand disease. There's a case of a 16-year-old boy who presents with recurrent knee pain and swelling. Whenever he hits his knee, it swells very large, and he's had a history of heavy bleeding following dental procedures. On exam, his right knee has decreased range of motion and a large effusion, and coagulation studies show prolonged PTT. The diagnosis would be hemophilia, which is an X-linked condition. It's a deficiency of factor 8. Hemophilia B is a deficiency of factor 9. Treatment with desmopressin for mild disease or factor 8 and cryoprecipitate for severe diseases. Next case is a 13-year-old African-American girl who presents with menageria and a history of bleeding gums. Her father has a history of excessive bleeding from cuts and bruising. PTT is mildly elevated, but PT and INR are normal. The diagnosis would be von Willebrand disease. You can confirm with a rhizocetin-induced platelet aggregation test and treat with desmopressin or factor 8 if it's severe. For leukemias and lymphomas in the pediatrics, there's a case of a 5-year-old presenting with increased fatigue and bone pains. In the past 2 months, she's been sick 3 times. On exam, the child appears pale with petechiae and palpable spleen. Labs show WBCs of 100,000 and increased lymphoblast. So this is ALL, acute lymphatic lymphocytic leukemia. Bone marrow biopsy would show greater than 30% lymphoblast, and you can treat with aggressive chemotherapy. This is increased in those with trisomy 21 before the age of 5. Next, we've got a 16-year-old girl with night sweats, weight loss, and fever. On exam, there are multiple 1 to 2 centimeter rubbery, tender lymph nodes around the left cervical and supraclavicular area. Lymph node biopsy shows Reed-Sternberg cells. This is Hodgkin's lymphoma. Next best steps are staging CT, and you're going to stage using the Ann Arbor criteria, and you treat with radiation or chemotherapy. Last, we've got an 8-year-old African boy who presents with a jaw mass. Biopsy shows starry sky appearance with a translocation of 814, and this is Burkitt's lymphoma. It's associated with EBV. Classic presentation in the more Western world is with an abdominal mass, and you would treat either with aggressive chemotherapy. Looking at some blood smears, we've got sickle cells on the left and schistocytes or Portuguese man o' war helmets on the right. And then there's an acute lymphoblastic leukemia. There's immature lymphocytes with granular chromatin. And then on the right, we've got a starry sky architecture of Burkitt's lymphoma. So this concludes sort of the hematology, endocrinology, nephrology sections. Next up, we'll finish out pediatrics with the remaining organ systems.
I am Professor Patrick.
Professor?
Dr. Professor Patrick.